Hi, everybody. Happy Friday. Thank you for joining us today for the second week of the 2026 ARC Michigan Disability Policy webinar series. My name is Emily Mullins. I'm part of the information and referral staff at Michigan Alliance for Families, which is a project of the ARC Michigan. A few items before we get started. We're on the Zoom webinar platform today. If you need any tech support during this webinar, you can message me using the chat feature. Attendees will remain muted for this presentation. A copy of the PowerPoint handouts and after a recording of this webinar will be available on the ARC Michigan website. I just posted the link in the chat for that. Recordings and materials from last week's session are available now. Feel free to enter your questions or comments on today's webinar topic in the chat during the presentation. I'll also be sharing links and presenter contact info in the chat. If you've joined us via the app on your phone, look for the pull-down menu at the top or bottom of your screen to access these features. Automated captions are available. You have the option to translate captions into a different language by clicking on the little caret next to the CC button to access those options. Now, let me hand this over to Sherry Boyd, Executive Director of the ARC Michigan. Good morning, Sherry.
Morning, Emily. Thank you. I kept going on and off camera. I apologize. Good morning, everybody. Thank you for attending this week's two public policy webinars. Before I introduce our first presenter today, I want to make a plug for our action alert that is out there currently around direct care wages and the 27 budget. If you could send this to your lawmakers, we would really appreciate it. You can use the QR code. There will also be a link in the chat. But it's really important that we hear from our lawmakers that our lawmakers hear from us because they're making decisions about next year's budget that will impact direct care wages. And we really, as you all know, that's one of our main public policy issues is trying to increase wages so that people can have a livable wage. So turning over to the public policy seminar, I want to introduce Lyndia Deromedi. She's the manager of the federal compliance section for a division of adult, home, and community-based services at MDHHS. That's a mouthful, but Lyndia's been around at the department for several years, and before that, she worked in the CMH and PIHP system, so she has a wealth of knowledge about working with and providing support to people with disabilities across Michigan. Lyndia is going to be talking about information and updates with regards to many topics, but primarily HCBS services and some EVV updates and some other things. So I'm going to turn it over to Lyndia, and here you go, Lyndia.
Thank you, Sherry. I appreciate that and welcome everybody. I'm happy to provide some updates. I will start this with the caveat. If you have been to this policy presentation previously in previous years with the ARC, you are probably familiar with Belinda Hawks, who was our division director for the Adult Home and Community-Based Services division. She has since retired, so I am here and I will try and give as broad of an update that I can, but I do want to just let you all know that there are some things in terms of our division updates that I did not address in this presentation. But I will say, some of you have asked there, her position has been posted. So we are starting that process to get someone hired to replace Belinda, although that will be very hard to do. So next slide, please. So I wanted to talk a little bit about the agenda items that we have, just to give you all an overview of what I intend on speaking on today. So the first is just an update on the World Health Organization Disability Assessment Schedule. So you will hear me reference that as the HUDAS. That is the acronym we use for that assessment. I'm also going to give a quick update on the community living support. So you'll hear me say CLS regarding those services and overnight health and safety. I'll call that OHSS as we move forward with the presentation. So this is an amendment that's currently in process for our 1915 state plan amendment. You'll hear me say ISPA when I refer to that. And also the habilitation supports waiver. So this specifically addresses us adding per diem, a per diem code to these services. I'm also going to talk about the critical incident reporting. So you'll hear me also reference that as CIRs. There are some changes that are coming up on the horizon based on our requirements for the CMS Medicaid access rule. I will also be providing a few updates on the home and community-based services rules and our compliance with CMS. So CMS is Centers for Medicare and Medicaid. So you'll hear me reference that acronym as well. And for home and community-based services, many of you have probably already heard this before. HCBS is the acronym you'll hear me use. Also, electronic visit verification, EVV, that would be the acronym you'll hear me when I reference that. I'll give an update on where we are with that. And then finally, just some other more general updates and resources. Next slide. Okay, so we're going to start off with the HUDAS. We can move to thank you. So I'm going to give you just a brief general overview for folks because I know many of you probably already have heard about the HUDAS. Maybe you have some information about it, but I also understand from our audience, maybe there's individuals who this is for the first time they are hearing about this. So the HUDAS is a 36 item assessment. It's an assessment screening tool that we intend to use for individuals, for adults who have intellectual and developmental disabilities. So how we're using that is we're going to use it to determine eligibility for 1915 ISPA. We're going to use it as a screening tool to identify those individuals who may be potentially eligible for the habilitation supports waiver. And we're also going to use it to inform person-centered planning. So as always, and what's important to mention when the MDHHS introduces a new assessment tool is that this isn't intended to be a level of care determination. We are required by CMS to have a standardized assessment tool. Many of you may have recalled us utilizing the SIS previously. Had a lot of not great feedback about the use of that. And so in turn, the department made the decision to look at another assessment tool. And the HUDAS was one that we made a decision on. So again, as I said, it's used for people with an intellectual and developmental disabilities who are 18 and older. But the Michicans, which is another assessment tool that's used for children up to the age of 21, that is the preferred assessment tool to use for those individuals who are in that transition age. So that's 18 to 21 years old. Next slide, please. So what does the HUDAS measure? So the domains of the HUDAS I have identified over to the left of the screen, and then to the right is our learning area. And you can kind of see how we have aligned them together. So the cognition is sort of our learning, where we look at the functional limitations. And so if individual has the learning functional limitation, the mobility, the self-care, some of them are exactly the same. Others are similar, but this is really intended to provide that tie into, if you're looking at the HUDAS domains, how would we be using that to determine functional limitation? So that's really primarily what this slide is for. So for participation, we kind of have that aligning with self-direction and economic self-sufficiency. Next slide. So I wanted to give a little bit of a background on how we selected the HUDAS. When we made the decision to no longer use the SIS, we got a lot of feedback from our PIHPs, our CMHSPs, our individuals served in terms of, hey, state, when you look at the next one, can you just make sure to think about this and to think about this? And can we have just a little bit of influence or just some part in making that decision? So we thought, okay, we can do that. So what we did is we created a it was a HUDA steering committee. So we had two steering committees. We had the first steering committee that helped us select the assessment. And then we just wrapped up another steering committee that has helped us with providing input related to our guidance, our training, our requirements. So we've been through two processes where we've had expert panels, and these are the individuals that have been involved in both. So we, of course, have the PIHP CMHSP staff. We tried to get some CIS assessors and those quality leads. We included beneficiaries. We included family members. We included advocates. And finally, of course, we included MDHHS staff. So this update is to say, hey, this is where we've been. And now, as you'll see on the next slide, this is where we're going. So we're ready to pilot this. It's been a long time coming. Everybody's been patiently waiting, which we truly appreciate. But we really wanted to make sure we got this done the right way. So we are starting our pilots. In fact, we've already started this work. So what we did in terms of selecting the pilots is we utilized many of the same CMHSPs and PIHPs that have been involved in this process, in this HUDAS development process. Many of them were very gracious and said, please let us pilot. We'd love to pilot. We'd love to be involved in this process. And we thought that that was beneficial because they have all of this information to where we got to this point. But we wanted to make sure that we also had a great representation of the state of Michigan, which is not necessarily the easiest thing to do because Michigan is large. Michigan has very unique needs in different areas. We have rural areas, we have urban areas. So we were really trying to get a good representation, but also in the time of testing, which we're really looking at July and August, and maybe even part of September to do the testing, we needed to make sure that we had a significant sample population. So we also had to look at, well, how many iSPA recertifications are coming up for said regions? How many HAB waiver recertifications are coming up for these regions? And also, what can we anticipate in terms of enrollment? Because to test this assessment, we need to test it on all of those areas. We need to test it for that front door access. Is it measuring what we need it to measure in order to be able to identify the medical necessity for someone to be on the iSPA? Is it also meeting the criteria for the recertification? Is it also being able to identify folks that are have potential eligibility for the HAB waiver? And for the recerts, when we are doing the HUDAS, because we will expect the HUDAS to be done at the front door and then annually thereafter, is the HUDAS aligning with the activities of oh my gosh, the FMLA, this is a Friday. It is our functional, it's the measurement of our activities, and I'm getting the word wrong, my apologies, for our HAB waiver. So we're making sure everything aligns. I cannot believe I forgot the acronym for that. This just goes to show we have too many acronyms in our system. So this pilot, or this slide is really just to kind of show like what we intend to do with the pilot, like what are the action items that we're looking for in order to ensure that the HUDAS is going to meet our criteria that we have. So I can go through this, but it's really just more of an informative, like, so you all know, hey, this is what's happening to ensure that this assessment tool is going to be effective for the state of Michigan and is going to do what it's intended to do. Next slide, please. So I wanted to also include the timeline draft. As always, our timelines are always in draft form because you just really never know what to expect. And so again, we're in that pilot readiness. That's what we're working on right now. And we are looking at that API, in addition to testing the assessment, making sure it measures what we need it to measure. We're also looking at how we can have an API connection from the electronic medical records to the data warehouse that we use at the department. So that way the department can start to get this data on the individuals, scoring. We can see if there's issues and trends, improvements, things of that nature. This data will come to the department through our data warehouse. So we're doing sort of two things at once. So when we get to that full implementation of the HUDOS, we will be prepared. So you can see on this, we're in the pilot readiness. We're in the pilot launch, which that's kind of what I'm talking about right now, the July through September. State readiness is in September. So that's when we're going to evaluate the pilot. We're going to apply any feedback. We're going to distribute readiness assessments. And if we need to make any changes with the assessment, the intention of the pilot is to do just that, to inform us if we are on track with this, with the way we have set up this assessment and what we need to change. It'll also provide us feedback on how did the training sessions go? Was it an effective training? Did we need to make some changes in the training of the staff? And get feedback from boots on the ground. What do our assessors say? What are individuals served and their family members saying? We intend to begin statewide implementation in October. So I'm going to just don't worry. Like, it's not like an end date. Like, if you're not all using this by 10/1, you're in big trouble. No, that's not the case. What we have done is we've built in a little bit of flexibility with our waivers. And so the intention is that we begin that statewide implementation. That means folks come up with a plan in terms of how they're going to implement it in their region, with the end all be all date of full implementation on 10/1/27. So it would be the beginning of the fiscal year for FY28, for fiscal year 28. For the assessment tool will be a requirement. It's not something that people, if individuals want to be enrolled in the iSpa, if they want to be enrolled and they have waiver, the HUDOS assessment needs to be done for adults with intellectual and developmental disabilities. And what I will say about this assessment tool, it is not as intensive as the SIS. You're not going to be spending 2 or 3 hours completing an assessment. It's a 36 question assessment. It is relatively straightforward. It's not at all time consuming. I think that will be a pleasant surprise for folks, that they're not going to be spending a whole lot of time completing this assessment. There is I'll call it like a smaller screening assessment. We will not be using that one. I think it's like a 12 question assessment. We are just going to stick with a 36 question assessment. And we did testing. That was part of the decision making at the very beginning in terms of what assessment to use. And the HUDOS got, feedback in terms of the HUDOS was, it was easy. It didn't take a lot of time. It was straightforward. It was relatively easy for family members, understood it, could use it, staff. So that was one of the decision factors related to the HUDOS. Okay, next slide, please. Okay, so I'm going to move on to the next topic item. This is related to the status of our community living support and overnight health and safety. We currently have an amendment to CMS about this, and this is per diem. I'm going to just focus strictly on the per diem related to this amendment. There are other things we amended in there, but for the sake of this presentation, I'm just going to focus on the per diem. Next slide, please. Okay, so we had many of you, if you've been involved in the state of Michigan system, probably recall pre-2019 that we had a per diem code. I think it was H0043. We had that, I think, for years. And then a decision was made to no longer use the per diem. And for all those folks who were not living in a specialized residential, we moved to the H2015 15-minute code. We heard a lot. We got a lot of feedback regarding this. And so we looked at the information, looked at the data, met with folks, and we're ready to bring that per diem back. But when unfortunately, it's not just an easy, hey, let's add this code and we can start doing it. We did have to amend our 1915I and our ISPA, our habilitation supports waiver. So per diem code is back. There are new sort of regulations around that. In addition to that, we created a per diem for overnight health and safety. We also added overnight health and safety to the iSpa. So that is wonderful. That's a really that's I think going to be easier for folks because previously they were using the 15 minutes H2015 for that, as well as there was a modifier to indicate that it was at night. So this just kind of talks about the changes for July 1st. So again, we're going to do the new per diem code. And again, this is non-licensed setting, and this is for individuals who are authorized for 10 or more hours of CLS per day. So that's the caveat, meaning if it's less than 10 hours, you must use the H2015 15-minute code. But if the individual requires more hours and is authorized 10 or more hours, the per diem code can be used. We're also bringing back the TJ modifier. And this is to allow for flagging for beneficiaries who are high utilizers of CLS services. So it's indicative of somebody needing 16 or more hours of daytime CLS. And the reason we have that in there is in terms of our data and the information we receive, this is very helpful for us to see in the system who are individuals that have higher needs, like that require that over 16 hours of staff per day. And what does that look like in terms of, how many of these folks are receiving services in the iSpa? How many of these folks are receiving services in the HAB waiver? Again, the overnight health and safety was added to the iSpa, again, pending approval from CMS. Let me just add that caveat. I'm going to talk a little bit more about that in a future slide. And then also the addition of the per diem T 2026. So that will be for individuals who, I don't think I put that on this, which it might be on the next slide. And in terms of the details regarding the per diem. Thank you. Yes. So this has the parameters, which I always think is very helpful for individuals to see and folks to see, to know, like, hey, where might my loved one, fall under in terms of what code is being used. And not that you all have to become billing experts. I mean, you got enough on your plate as it is, but it is helpful in terms of when you see your authorization, what that may look like. So if you have an individual under 10 hours per day that needs CLS, you're sticking with the same code you've always been familiar with. But if it's 10 to 15 hours, it gets bumped up to the H0043. And then also 16 or more has the H0043 TJ. Let me just add, typically on an authorization, you are not going to see that modifier. The modifiers are, again, more information that gets submitted on the claims part and is really just informative to the department, to the CMHSP, the PIHP, the department. So I've never seen them. I've never seen modifiers on an authorization, but I can't say that maybe a CMHSP might not add them, but typically those are going to be on the back end. Here's the parameters for the per diem for overnight health and safety. That is anyone who utilizes or authorized 6 or more hours of overnight health and safety. And the max for that is 12 hours per day. And then the 15-minute overnight health and safety, that code is still in place, but that will be for beneficiaries who are authorized for 6 hours or less of overnight health and safety per day. Next slide. Okay, so this is where I wanted to give an update on the amendment status. So we have submitted the amendment to CMS. CMS has begun their review. CMS has already requested changes of both the iSpa and the HAP waiver. We have made those correction and changes, and we just submitted those back to CMS. In fact, one was yesterday, and the other one was, I think, on Monday. So we're waiting, kind of this back and forth is, CMS reviewing, sending us questions, sending us changes we need to make. Sometimes we have questions back to them. So now we're back to, okay, we know what CMS wants. We made the changes, and now CMS, it's back in CMS's review. We still are on track for the July 1st, 2026 approval. But what I will say is if we continue to have this back and forth, we will have to ask for an extension. We did do an expedited review for the HAB waiver just because of our internal processes took longer than we expected, and CMS granted us this, which is nice because typically they'll take 90 days. We were a little bit worried that for the HAB waiver, that wouldn't get approved until October, but right now we are still on track for July 1st. Now, what I will say about that, just because I know I have folks in this presentation or who are here listening to this that are individuals served, that it may take a little, the per diem may not be effective for CMHSPs and our PIHPs July 1st, because keep in mind, you've got to do an amendment to the plan of service. You've got to make some changes. They have to add this code. So it shouldn't disrupt any services for you all. I think there'll be more of a convenience, especially for folks that share, that maybe live in a house together. Like if I lived with somebody else receiving services and we sort of split the 24 hours, that the billing component of that is going to be much easier. The other thing that will be a relief to probably many ears here is that per diem codes do not require EVV. The EVV requirements are lifted when you have a per diem code. So if you're a family member or you're an individual served and they require, more than 10 hours per day and they'll move to that per diem code, they will no longer have to do EVV. But let me just put a but. You still are required to do all of those other things related to receiving Medicaid services, in terms of CLS. Like you still got to do a progress note. You still got to do whatever requirement is needed for you to get paid for your service, but EVV is off the table. Next slide, please. Okay, so I want to talk a little bit about critical incident reporting changes. And I know for many of you, you're like, why do I have to know this? But it's important that you do, especially because this is a requirement for anybody receiving Medicaid services in terms of having these reporting requirements. So I thought this would be helpful for you all to see and just to give you sort of a heads up in terms of what is going on. So next slide, please. Okay. So this is related, these changes to our critical, we already have a critical incident reporting system. We already report on, we have them defined in our waivers, folks know what they have to report on. But CMS has created more specific requirements in terms of this reporting must be identified as a critical incident reporting, and you must have an electronic system to do this. And the state must have more monitoring of this. It can't be really a delegated function related to this. So I wanted to make sure you all knew, like, hey, these are the changes and these are going to be the requirements and where we are at with this, because we do have a deadline. CMS always imposes a deadline for us to get this done. What I will say, the good news is we already have an automated system. I like it. I think it's a great system. Others may argue with me, but I think it's a great system. It's an API, so it's a direct connection between the EMRs of our CMHSPs and to our it's called the customer relationship management system is what we're using now. So we already have that criteria met, which is wonderful because that often can take some time to get implemented as a state. But what we don't have is we're not using. So I want to let you know this stuff is getting reported to the state. What is listed on here? Abuse, neglect, exploitation. That is getting reported to the state, but it's not necessarily getting reported through our critical incident reporting system. And so that's the major change we have to make. So all the things that you see highlighted here are what we now have to have the system change to report in this system. So like verbal, physical, sexual abuse, emotional abuse, neglect, typically, and where we've gotten that data from is our ORR investigations, but now they will have to be reported to us via a critical incident report. The misuse or unauthorized use of restrictive interventions, that is also reported to us, and that's sort of a critical incident report, but there's also a reporting mechanism to the PIHPs who then report that information to us. In terms of medication errors, that is already one of our critical incident reporting, but what CMS added is now you must consider if you make a telephone call or you have a consultation with a poison control center, that now rises as a critical incident, which must be reported to the department. I think incident reports are typically done in this situation, but now it rises up to the department knowing about that. And again, unexplained or unanticipated deaths. We do have deaths reported to the department, but this is very specific in terms of what CMS is looking for. And again, those caused by abuse or neglect, of course, those already come up to the department, but not through the critical incident reporting system. So again, what is highlighted here? The reason I put the highlights in here is because I wanted to be able to show these are the things that are going to require a change. Next slide, please. Okay, so this is kind of there's some significance with these changes here. Some of them are just in the way that we report to CMS, but also CMS is now asking the department, like, you have to have investigations. Now, we already have investigations with ORR, but CMS is saying, well, we need to see like what investigations the state is doing. And so they're also giving us the 90% performance levels. We've never had a performance level per se regarding critical incident reporting. So this is going to be new in terms of how we're going to measure that. And I'll be honest with you, we haven't really fully developed a plan in terms of how we're going to measure that. But all critical incident investigations are initiated, they're investigated, they're resolved, and then corrective actions related to the critical incident reports are completed. Right now, we call these remediations. Most critical incident reports that we have reported that have remediations are investigated, but this is sort of a different way that we need to look at this. And we have been looking at what other states are doing. And it's always interesting to see how we differ from other states. Many other states have they have state investigative bodies that do this work, where we slightly differ from there in terms of we have ORR, but then we also have we have LARA that does investigations. We have Adult Protective Services and Children's Protective Services that also does investigations. So the other thing related to this, and I think it's on the next slide. Let's move to the next slide if that's okay. Is that we have to be able to coordinate our investigations as a state. So that's something else that we are going to have to really take a look at and figure out how we're getting that data and what we're doing with that. So other changes here, the investigate resolve, that's different. That is different in terms of they're sort of saying the department must investigate. Or have it not the department must investigate. We have to investigate if the agency fails to report in time. That's when the state has to go in and do an investigation. But they're just, we call it remediation. It's just a little bit of a change in terms of the language. Investigate, resolve too. So we just have to make sure that we are very clear in our system that this is an investigation and there's resolution at the end. So it's a little bit different than us saying corrective action. The big thing is that we as a state must separately investigate the critical incident if the investigative agency fails to report the resolution in our state specified timeframes. And we have to define those state specified timeframes. Again, we are starting work on this, but we have not made any final decisions. And also an incident management system assessment every 24 months. that is directly to CMS. Right now, we do report our data in our 372 report, which is our C waiver report. To CMS, we also have an iSpa report, but that's every 3 years to CMS, where we also report the data for critical incident reporting. But this is now a separate report specifically for critical incident reporting that goes to CMS. And I think from my understanding is that this is really to see, is your incident management system, is it effective? Is it doing what it needs to do? And what I'm told is that if they're able to get that and see that we can demonstrate that we will go from every 2-year reporting to every 5-year reporting. Next slide. Okay, needed a drink there. So I talked a little bit about this, but this is where we've done some work. We've had some internal meetings regarding the requirements. What are the implications of the changes? We still continue to meet. We're looking at also the design. What do we need to change in our design? What are our timelines? As I said earlier, we are in the middle of an amendment right now. When you are in amendment, you cannot make any further changes. So we have to finalize this amendment, and then we will start the work to amend our 1915C waivers and iSpa to reflect these changes. So we're trying to time that as such where it will start in FY28. What I failed to mention in this presentation is that our requirements to CMS for this must be done by July 9th, 2027. And so we are on track for those changes. It may not feel that way, but I believe we are. And we are going to ask CMS that to see if they're okay that we start this reporting in FY28, because it's going to be a little bit wonky sort of reporting to CMS on, it's probably like 9 months of reporting this way, for certain incident reports, and then changing that. So that will be part of our request to CMS is that, hey, we have everything in place, but we'd like to begin this on 10/1/28. Okay, next slide, please. Okay, I want to give a quick update on home and community-based services. We'll go to that next slide. So wonderful news that CMS approved our HCBS corrective action plan. So this is, if many of you have been around, in the HCBS requirements have been around since 2014. Every state had to submit what was called their heightened scrutiny list. And kind of what CMS did is they said, well, what's kind of your corrective action plan to ensure all these settings are in compliance? And we had to first show CMS, hey, this is what we've done. This is what we're doing. And CMS said, okay, we're good with this. Now give us some samples because we want to see this and we really want to see if this was effective. CMS also came out to the state of Michigan and did their on-site review in 2024. So they added some of the changes and some of the things that they saw that we had as a state that were, not quite meeting the mark. So they finally approved our corrective action plan, which is wonderful news. We've been waiting on this for a while. So kind of just a level set, again, this applies to anybody receiving services on any of our 1915C behavioral health waivers, as well as our 1915 iSpa. Also, the My Choice waiver, we were working in coordination with CMS, so with our My Choice team. So they also are on the same, they have different corrective actions just because they serve a different population and have somewhat different services. We have a lot in common though. They are also part of Michigan's corrective action plan because they are also another C waiver. We must be in full compliance, or what we've told CMS is the things that we're still working on will be in full compliance by September 30th, 2026. So we are on track for that. I'll also let you know that as a state, we are monitoring some of the concerns at that federal level regarding HCBS services and fraud, waste, and abuse. We have been tracking on that. I think for a state, I feel like we're in pretty good we are pretty good in that area. I don't know that we have this. I mean, we have a robust system that is monitoring that, checking that, ensuring that this isn't going on. And when we have found it, we have taken action. So I know it is a concern. I understand it and I feel it too. We are monitoring that, and we'll just keep doing that until we hear more. Next slide. Okay, so I'm going to update you on the electronic visit verification. I am going to give a caveat that I am not the subject matter expert in this area. So if you have very specific questions about EVV, which is fine, you're more than welcome to put in the chat. Many of those are likely going to have to go back to my EVV specialist because this is one area that has very specific details and nuances that I sort of know, but I am not the expert and I really don't want to provide the wrong answer. So I wanted to make sure I let this audience know that as we move through this. So I'm going to give a brief update. Next slide, please. So just a couple of sort of the implementation process for EVV. We went live in 2024, started with the soft launch. And again, claims and billing are still not tied to confirmed EVV visits right now. We do have a state-sponsored system that we use. That's what you'll hear, HHAX Exchange. The second part to the behavioral health that was really sort of one we had been waiting on is sort of that self-directed arrangement. And that went live, I believe it was in April. It was March or April. Next slide, please. So talked a little bit about HHAX. So they have been in communication with our financial management services agencies. We sent this letter out in January, sort of saying, okay, it's time, get prepared. We had a kickoff in February with the fiscal management services agencies. There were user training sessions that went out to them that was held in March. And then we officially went live in March 23rd of this year. The Medicaid provider manual was also updated, and it does provide it allows that ramping up period to come into compliance. There was also some compliance training sessions that were offered in March and April of 2026. Next slide. So again, just kind of touching base on the Medicaid provider manual policy. And again, I thought this one was important because it talks about the exemptions in terms of who doesn't need to report. And so that is those individuals that are live-in caregivers, congregate settings, and services that both behavioral health and home health services being provided to the beneficiary at the same time or during the same shift by the same caregiver provider. I know that this is a big one. We have had lots of internal conversations about how we manage this population of folks in terms of the EVV requirements. We haven't made, we're still trying to come up with a good plan in terms of how to address that and how to address that from an EVV requirements perspective. So more to come on that. I mean, the good news is you're exempt if you have those situations, but I can't guarantee that you'll be exempt forever. But for the time period, we are exempting that population. Next slide. So again, hey, what can you expect? What's next for behavioral health? So again, we had that Medicaid provider manual update that went into effect April 1st. And that does have information about the quarterly schedule for EVV. Went live with SD self-direction services in the spring of 2026. And then the Medicaid provider manual also includes the ramping up period for that group. So next thing we can talk about is the claims and billing for EVV, because that is still required. So first we have to end that current soft launch date. It's not been identified yet, but as soon as it will be, we will let everybody know. And then also there's other program areas that may have different dates for tying the claims into billing with confirmed EVV visits. And that's important because EVV affects, I think it's 7 programs within the state of Michigan. And we've always had this sort of everybody's had different launch dates in terms of coming into compliance or working with EVV. So I don't think that that's going to be any different with the billing and claims perspective. So if you hear like, oh, my choice is doing it, it doesn't mean like, oh my gosh, shouldn't we be doing it at the same time? It just might mean that we have sort of this I'm trying to think of the right term. We have different dates for each program. So don't get concerned about it. Or if maybe behavioral health has to go before my choice, it just might be what was decided in terms of as a state, what is the best way to organize this requirement. And again, working with HHAX, there's coordination with that. And if they were to try to do all 7 programs at the same time, that would probably be a disaster. So next slide. So I love resources. So here are some resources in terms of general questions about EVV, general information and updates from MDHHS. This is the website. If there's provider enrollment questions, we have this web page for folks to use. And I think the next slide, we can move to that, is also a list of resources. Yes. So this is more specific to the HHAX, the system you use for claims. And this kind of identifies the implementation in Michigan. And then as always, there's the phone number for the help desk for HHAX. Okay, next slide. So this is just kind of I just have a cluster of updates and resources just for this group. So we can go to the next slide. Many of you might be aware that we have been working as a state on a case manager 101 training. So this would be a statewide training for case managers. And the intention behind it is really just to ensure that there is consistency in terms of how case managers are trained and what the expectations of case managers are, and that they have the information necessary to be able to do their job and do their job effectively. We've noticed some inconsistencies across the state in which case managers are trained. Some areas do it very well. Some areas, may be lagging. So we really wanted to make sure that there was consistency across the state, and B, that we ensured that everything that's required for a case manager to learn and do, they know. Because we know we have different populations of individuals served, which means some of those requirements may look differently, or the way that you write a plan of service. If you were a case manager for somebody who was part of not guilty NGRI, which is not guilty for reason of insanity, there are different requirements that you must do as a case manager for those individuals. So those sort of specific areas, we just want to make sure that folks know. Even the transition planning, what is the case manager's role in that? So where we're at with that is we are still gathering, we're having interviews with different folks, and we're gathering initial feedback. So we've done that with our MDHHS staff, and now we're moving toward advocates and interviews. So it's advocate interviews and a focus group. So we do have a meeting in June already scheduled. I want to say it's like the second to last week in June, or maybe the last week in June. So we're, again, getting feedback regarding this. We just really want to make sure that we have a good representation of folks in terms of what needs to be included in this training to make it successful and to ensure that it captures everything. Next slide. I just want to give a brief update on Wasco. I also wanted to make sure that people had access to the links where you're going to find some good information about activities that we've completed and what we're working on. So on 10/1/25, the promulgated policy, so this is in the Medicaid provider manual. So you will see the bulletins 2531, 2541. On 12/25, we provided a guidance examples and they were published. In January 2026, we launched a new self-directed services website, and that has a lot of information on it. I would recommend anybody go to that to see what is there as a resource. And one of the materials on there that I think is very helpful is frequently asked questions. And what I will say about that is we try and update that every time we get a new question that isn't already addressed. So if somebody sent us a question to the federal compliance email, we would respond to it. And if it was a different question than we've already received, we're going to update that FAQ to reflect that question. So, it's very important if you do have questions that you utilize, and that's under that current and ongoing, that you utilize that MDHHS behavioral health compliance at michigan.gov email. Now, I'm going to be completely transparent here. We go through those, we answer those. You're not going to get, there may be really unique circumstances where you get a response within 24 hours, but typically it's going to take, I would give us at least a week, just because these are questions that we want to make sure that we are looking at and that we answer completely, or as much as possible that we can for folks. I think the secondary part to that is we are working on adjusting and updating our technical requirements materials. And that is related to the self-determination technical requirements. I call it our self-direction policy. And then we have the self-direction implementation guide. So we are working on that actively. We're getting close to having that be completed. And what we're trying to do is combine both of those and get those into policy. There's some discussion about whether we may put that into the Medicaid provider manual. We haven't made any decisions. But what you will end up seeing is sort of, this is policy. This is what's required. And then you'll see a technical guidance. So the technical guidance will be like, how do you do this? Like, what's the process? And so I think by consolidating, and again, we're not going to lose anything. I want to assure, because I know there's probably some advocates on here who worked very hard on the implementation guide. And I love the implementation guide. I think it's great. But really what it's intended to do is sort of combine what's been in the implementation guide and what's been in the technical guidance. The technical guidance will probably be significant. Well, I'm not going to say significantly larger, but I think it's going to be a longer policy, and the technical guidance will probably not be as large because it's not going to include the requirements, if that makes sense. So I've appreciated everybody's patience with that. I know you've all been waiting, and we are actively working on it. Also, keep in mind, there is an internal process for approval that sometimes takes a little bit longer. I would love to be able to say we have this hard, fast date of when we're going to get it done, but I can't predict how long that internal review is going to take. I know we have a goal of the fall. I like to be that's our ultimate goal, but I always hate to give a specific date because, again, I don't have any control of that internal review. And sometimes there can be a lot of back and forth with that. And we are talking about document. I mean, if it were one page, that would be different, but these are documents that are going to be multiple pages. So I do want to be transparent about that. And again, appreciate people's patience. Next slide. I know this has been on a lot of people's mind, and what I will say is I'm nowhere near an expert here. I am learning as all of you are with this, but I thought it might be helpful for me to include just some resources that I'm aware of, and I recently just was made aware of about Medicaid HR1 that are from the state of Michigan. These are MDHHS resources. So the first one is our web page. It's the Medicaid HR1 hub, full of information. I was able to kind of peruse through it. I wasn't able to get through the entire. There's a lot of information on there, a lot of helpful information, but I did see it and I thought, wow, this is wonderful. And I was just made aware of this, I think it was last week. So the timing was great so I could get this up and running. I do know that Michigan is really trying to, we're trying to get the word out there. They're still waiting on some finalization from the feds that is holding up like anything that would say, this is for sure what you can expect. But I do think you're going to find the information on this webpage very valuable. Also, there's a great FAQ. It's the SNAP. It's related to SNAP benefits. And that is on the web, on the following web pages. And I believe you're all going to get a copy of this PowerPoint that are also very helpful. So this is more just like me saying, hey, here's some resources for you. I don't have any answers for you. Maybe this will provide some guidance, but if it makes you feel any better, Michigan is working on this. They are really, really, really working on this, and they are really trying to make a good plan or plan as best they can for the state of Michigan in order to meet these requirements. Okay, I think that is my last page. Okay, questions?
All right.
I know we've seen a lot.
So let's start with the HCBS um, corrective action plan. Can you provide some more information about what that was in regards to? Is it about conflict-free access or something else?
So it's all encompassing of HCBS. So it's all the requirements that we have for HCBS. Excuse me. And again, when CMS came to do their on-site review, there were things that the state was out of compliance with that we needed to be in compliance. I'll rattle off a few off the top of my head. One was the having modifications or restrictions in the plan of service that had all of HCBS requirements in it. That was one that we were not in compliance with. We were also not in compliance with, oh goodness, there was a little bit of, there was conflict free in a few that we weren't in compliance with. We were also not in compliance with, and this is terrible, I'm trying to remember. We had a few settings that were utilizing what I'll call like reverse integration, which CMS said is not allowed. We had the training, the HCBS training to providers. We were short on that. So we had to come up with a corrective action plan for HCBS training for providers that provide CLS as well as case managers. We were also short on the summary of rights document, which goes to residential settings. And that's really an individual's protection for eviction, because that has to be very similar to individuals without disabilities in terms of that protection. Those are some of the things. And so we have had active corrective actions that have been happening since CMS's visit in 2024 that we have started to come into compliance, that we are in compliance with. So, you know, the major things that are sort of sticking out right now that we need to focus on is the provider training, which we have finalized. Well, it's almost finalized. We got feedback from providers, and now we're looking at that implementation phase. I know we're not going to get all of the providers trained before the end of September, you know, the end of September. But I think as long as we get that process started and have a plan for completion of those folks trained, we should be good. Yeah, hopefully, I mean, there's a lot to that question, but I hopefully that kind of gave you a little bit more information.
Thank you. Is this also related to skill building providers not being the same person as the support coordinator for day programs?
Yes. Yeah. That would be part of that conflict-free requirement. Absolutely.
Okay, thank you. Um, for our next bunch of questions, I'm going to move back to the slides where you're explaining the different
Dan.
hours allotted per day.
Yes.
And I'm not sure if it's this slide or this next one, um, which would be more useful. But the questions are, first question about overnight. Um, if people sleep 8 hours a day, how could you ever be over 16 plus hours a day for CLS? So is that a typo or are we not following the math?
Let me do the math. Isn't that 24 hours? If they sleep over 8 hours, then so I think I see if they're more than 16 hours. So you're saying if somebody has more than 16 hours but sleeps for more than 8 hours. So we're going into the weeds a little bit here.
Can I just interject? I
Yes.
think the question actually was, assuming that people sleep 8 hours a day, how do you ever get to that 16 plus hours? The short answer to that is that lots and lots of people, I know many of them personally, do not sleep anywhere near 8 hours a day. So you can easily have more than 16 hours of CLS with many of the people that I support.
Okay, I see where we're going with this. Okay, thank you, Jan. um, So, listen, I think this is going to be individualized. It's going to be with the person. I mean, what you're talking about is the difference between a TJ modifier for the daytime and no TJ modifier. And again, that is going to depend on the person. Do you have to be like, oh my gosh, for this week they slept 12 hours and we only said it was 8? People have everybody's different. Things happen in their life where things happen. A per diem is really to allow a little bit of that flexibility in terms of what's a typical normal day for an individual. Don't try and get yourself stuck in like, but sometimes they get a cold, and when they get a cold they sleep a lot. So do I have to then amend? No, 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 don't do that to yourself. Like, these are individuals, these are people, like they're going to have those nuances in their life. And you really just want to go with what is typical of the individual. And again, you're always looking at things. If for whatever reason something changes, where you're seeing a pattern, and it's a pattern, it's not going back to what it was before, then maybe that would require a need to amend your plan and take a look at those. But otherwise, I would just say, look at what is pretty typical for this person.
All right, thank you. Our next question is about EVV. Is
Oh
that
boy.
is that expanding to skill building? I don't know if you need the number
No.
H2014. Okay,
No, 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 no. It's just for CLS and respite.
perfect.
Because skill building is supposed to be a service provided out in the community. And so that would make it already in compliance with EVV, if that makes sense. Because EVV, you only do EVV if the person is getting services in their home. So that's why it only applies to CLS and respite.
All right, thank you for that explanation. Um, some of these questions are mostly numbers. So allow me to ask regarding the H0043 and T2026. Do you have updated rates for these?
Um, I I'm I think they are going in. I thought we were going to put them in the Milliman. I thought they were going to go in the starting FY 27. I need to follow up on that one. Now keep in mind this, we don't have rates that the state just puts out that the rate certification letter, and then they put out with Milliman Oh my goodness, I'm losing my train of thought. Um, yeah, I can get back with that. I'm not really, I don't know, to be honest with you.
All right. Next question. We heard Sherry Boyd talk about the direct care worker challenges going on right now at the start of this presentation. So with those challenges in mind and the CLS rate, um, there's a concern that it's not being funded for the recent minimum wage increase and the impending minimum wage increase next January 1. Um, Worries about how to plan appropriately to fund and calculate these new rates. How can we ensure that CMHs set and pay the appropriate rates?
So I think we're handling that in a couple of different ways. You know, we have active conversations at the department in terms of looking at that. I know there is, we are planning on getting a survey sent out from Milliman regarding, and this is mostly related to self-directed budgets and those rates, but I do know there's active work that's being looked at in terms of those rates and ensuring folks are you know, getting what they need in order to have an effective budget. I mean, I think, you know, the pass through, and I thought there was a memo that Kristen sent out, and I'm going to have to double check that. That was related to directly to the pass through. But in terms of that legislative, that's not anything that we would have control over in order, you know, to continue the current rate, the what Sherry was talking about. I think if you have specific concerns about your CMHSP, not you know, adding some of these required times, your best bet is to send that email to the behavioral health. And if it rises up to a contracts issue, we'll send it to contracts. But we do take a look at those because I think some of this could be individual or could be specifically related to one CMH too.
We did have many comments in the chat that some people need overnight care for safety, choking hazards, medication, seizures. So lots of reasons why somebody might need 24-hour care. So this that people chimed in with. This question goes, I think, all the way back to your first slide, so I'm not gonna back arrow that whole way. But when you were talking about the HUDAS, if you've qualified for the HAB waiver, do you still need to do that, or is that only for new people qualifying for the waiver?
It's everybody. It's anybody who's an adult with IDD is going to have a HUDOS done every year.
Okay.
And this is, as I said in there, this is a CMS requirement. So I know that there are some folks who, you know, don't particularly like assessments. I don't blame you. But this is a requirement. This will be a requirement moving forward, minimally annually at the front door. Or if people want to utilize it, if changes occur, there most certainly can do that, but it is minimally annually.
Next question. You've mentioned this corrective action plan. Is there somewhere that people can view it or view our response, the state's response to it?
It is somewhere. I'm trying to, I think I'm going to have to get back with you on that one. I know we posted it. I just am not, because it's a shared like it's a shared response with the My Choice waiver. So gosh, it's terrible that I can't remember. I'm not sure exactly where it landed.
Okay.
So, yeah, my apologies. I want to say it's on our HCBS webpage, the MDHHS HCBS webpage, but I'm not 100% sure. It's been a while since we posted it.
All right. We've had some other questions in the chat about the links that you've talked about. And I just want to remind folks that this PowerPoint presentation that you've presented today is available on the ARC Michigan website now. And the recording should be available probably by Monday. So if we need to come back, look at it again, listen to Lyndia again, we'll have that option. So that that little bit of information there. So our next question, Lyndia, you were talking about training for case managers. Is that specific to IDD, or is this the same case manager training that would apply for people with like a substance use disorder?
So we're hoping it can be sort of for everybody, and I think that's where the sort of the specifics would come into play. So it would, like, if is a section, hey, if you're providing services to individuals with intellectual disability, you're going to go in this direction or have this part or of the training. And if you're primarily SUD, you're going to do, training number 2, or, I think that's kind of what we had talked about. We haven't made any final decisions, but we understand that there is a need to be specific about the specific population you serve. And that's kind of why I gave an example of, if you're a case manager for somebody who is identified as NGRI, you have different requirements that you must follow. So what you have to do is going to look very different than somebody who's not on NGRI.
Understood. Next question, or actually our final question at this point. Is there going to be training for support coordinators to implement or take the HUDAS assessment?
So what I will say, and again, these are just kind of discussions we've had as that steering committee, is I believe our CMHSPs and our PIHPs will determine who will be the trainers. So I cannot say to you with 100% certainty that it's going to be every single case, or I'm sorry, who are going to be trainers and who are going to complete the assessment. So I can't say with 100% certainty that every CMH is going to have all of their case managers trained on the HUDAS. But what I can tell you is there will be a training. There will be sort of like what we envision as sort of a train the trainer module, where at either the PIHP level, CMHSP level, both, they have a trainer, then they train the folks who are going to be the assessors. Is it going to be every case manager? I don't know. But there will be a training if that helps in terms of answering your question.
All right. I think that brings us to the end of our questions. So thank you everybody for typing in the chat. It is 10:43, so we have just a moment before our next presentation starts. So thank you, Lyndia, for joining us today. We always value your presentation.
Well, thank you, and I appreciate all the questions, and everyone have a wonderful weekend.
All right, thank you. And shortly, Jan Lampman will be joining us for a presentation, so stay tuned.
Thank you for returning, everyone. We want to move on. As you know, Children's was not able to, or you may not know, but Children's was canceled, their presentation at the last minute from MDHHS. So we pivoted. We had a request last week to look at the Medicaid manual and provide some information about how to use it. And Jan Lampman offered to do that. So here we are. I'm going to turn it over to her. I think many of you know she does a lot of advocacy statewide and she knows a lot of things. So go ahead, Jan.
Thank you. Oh, I like that. That's kind of a cool introduction. Can we get so that I can share my screen? Is that possible? Okay, thank you. Let's see here. I'm going to go ahead and just share I have a few slides. Yeah, everybody likes to have slides. So we're going to start with some slides and we're going to talk about what Medicaid covers and how to assure you can get what you need, right? And so the place to find out what Medicaid covers is in the Medicaid Provider Manual. So we're going to talk a bit about that this morning. So first I wanted to just talk a little bit about history of for people with developmental disabilities in Michigan and how we got to the place where we have to look in a Medicaid provider manual that feels kind of medical, right? Prior to 1976, primary services for people with IDD was really institutionalization, or you stayed at home with your family. In 76, the Mental Health Code was revised, establishing the rights of people served along with due process rights, which was a really important step towards getting to that place where we could access services and supports using public dollars. In the 80s, community mental health agencies were given primary responsibility for supporting all people with developmental disabilities in the community, including those folks that had been institutionalized historically. And then in October of 1987, the first habilitation waiver took effect in Michigan. And that habilitation waiver is a Medicaid program, right? And so Medicaid began to be more in the forefront and more primary in funding services and supports for people with developmental disabilities right around that time. So how did we get from that institution to the community, right? So, the Social Security Act created entitlement for institutional care based on medical necessity, based on the need for that level of care, right? Section 1915 of the Social Security Act allows for states to apply for waivers, which would waive the requirement for institutional care and allow for home and community-based services. So we've got all of those, that's our habilitation waiver, our I-SPA, my choice, those waivers that we keep hearing folks talk about. Because of that, because we now are funding a lot of our services and supports for people with developmental disabilities, with Medicaid money, that's a health plan, right? Then we had to create medical necessity criteria. Medicaid requires cost sharing between the feds and the state. That's an important thing to also remember. So anytime you're using Medicaid funding, you're using a combination of state and federal dollars. And so all of the strings that are attached to that through the Medicaid programs and the Medicaid waivers are in effect. So what are the things that have influenced home and community-based services? Oops, historically, I don't know why it did that. We updated the mental health code in 1996 to include person-centered planning as a requirement for developing that plan of service. I think that's really important. Then we have, the Americans with Disabilities Act was signed into law in 1990. That plays a very big role in what kinds of things then were incorporated into our Medicaid waivers. In 1999, the Olmstead decision was so pivotal in codifying a person's right to live in their own home and receive those necessary supports, right? So that was like a really important decision that allows states to really enforce that notion of using a waiver and not placing people in institutional kinds of settings. And then here in Michigan, we closed our last regional center for people with intellectual and developmental disabilities in 2009. And so some of those are things that really have influenced what the landscape looks like and what kinds of things have ended up in the array of services that you can receive using the Medicaid dollars, right? So those things have all been things that have influenced what ends up in the Medicaid provider manual. Michigan has a number of waivers, like I said, that serve people with intellectual and developmental disabilities, including these ones that I've just listed: the habilitation waiver, the I-SPA or state plan, the My Choice waiver. There are people with developmental disabilities that become qualified for that. Children, the children's waiver. And then the SED or severe emotional disturbance waiver for children, you often think of that as specifically for kids with mental health needs, but lots and lots of kids with fetal alcohol spectrum disorder end up being referred to that waiver, that particular waiver. So again, it's a waiver that can serve people with developmental disabilities as well. So those are all waivers that are included, like the rules about them and the services that are offered about them are included in that Medicaid provider manual, right? So each of the waivers have specific services that can be funded. Each of the waivers have slightly different eligibility criteria. And each of the waivers may have specific requirements for providers, right? So, for example, if you're a community living services or a CLS provider for children, you need to have first aid. Whereas if you're serving adults, you don't need that unless the adult tells you they want you to have it. For children, background checks need to include the central registry. Obviously, for adults, we don't currently have a central registry, so you don't have to do that. So it's really important that you are informed about what waiver you're on or that you're using to get your services, what waivers you're eligible for, and then what are the services that are offered in each of the waivers, is specifically the one you are getting, and then what are the requirements for that waiver as well. So all of the waivers include medical necessity criteria and requirements, right? And that's listed in the Medicaid provider manual. So the behavioral health system uses that term medical necessity to describe what's the supports that might be necessary, right, to help a person achieve their goals. Medical necessity is described in the Medicaid provider manual in general is described as supports that are designed to assist the beneficiary to attain or maintain a sufficient level of functioning in order to achieve their goals of community inclusion, participation, independence, recovery, or productivity. And so that's a pretty all-encompassing sort of medical necessity criteria. But if you can remember all of that and think about how is the support I'm requesting going to help me in one of these areas, then you have a good start going on. So I want to talk for a minute about goals and medical necessity. And this is a slide that came right out of last week's training. Some of you who were here last week will remember this. It's not appropriate to ever determine that somebody's goal in life is not medically necessary. That's not what medical necessity means. Medical necessity is connected to the services that are provided by the Medicaid funding, right? So as such, specific requests for service are examined based on medical necessity criteria, right? Is this service going to help you achieve one of those, community inclusion, participation, productivity, all of the things. So any requested services need to be connected to something that is medically necessary, right? They need to be helping you address what the Medicaid provider manual describes as medically necessary. They need to help you meet that need. So it's really important that any requests that you are making for services are clearly tied to your goals and objectives and explain why this is the best intervention to help me meet that need, right? So I'm asking for community living supports to help me learn some social skills so that people want to talk to me when I go out in the world. When I go to that party, I need to learn some skills about how to greet people. I need to learn some skills about how to carry on a two-sided conversation. Some of you who know me, I might be describing one or more of my family members that get services. So it's really important that you are tying requests for service to something that is going to help you achieve a medically necessary goal as defined in that manual, right? So how can you find out what is available with your waiver, right? You can Google it and, the AI will tell you a list of things that are covered, that are covered services with, like, say, the habilitation waiver. I'm going to tell you, though, I like to go straight to the horse's mouth. So I'm going to unshare for a second, and then I'm going to reshare because I'm going to take you right to the Medicaid manual. Let me see here. All right, I'm going to do this. Let's see if we can make this happen. All right, do people see something that says Medicaid provider manual? If someone
Yes.
Okay, perfect. So this is and I put the website in the slides, right? So you click on that website that I put in your slides, and this is what's going to come up, the Medicaid Provider Manual. So then you're going to say, I need to find, this is a big book. This is a big manual. So I'm gonna open up the what do you call this thing? The table of contents. I'm going to open the table of contents, and I'm going to look for behavioral health. Here we go. Behavioral health and intellectual and developmental disabilities. I'm going to click on that. And then I'm going to have a couple of choices here. And I am going to click on the behavioral health and intellectual and developmental disability supports and services. And now where I am located is the section of the gigantic Medicaid provider manual that tells us all the things we need to know about the behavioral health and intellectual disability supports and services. Like what are the Medicaid rules around that? What are the services that are offered, etc. If you go, I know that I'm using a MacBook, and so mine looks a little bit different, but there's always a search bar. If you go to the search bar and you have a specific topic that you want to examine, you can type it into the search bar. And then on the table of contents side here, it'll list every single time those words that you typed in there are referenced in the manual. And so we're going to do that in a minute. But first, I want to just kind of go through this table of contents with you so that you have a feel for what's in this thing, right? So there's some general information. There's some conversation about, like MDHHS approval of the items in here. There are some standards things. So like the network adequacy standards for the behavioral specialty health system. So when you hear a CMH say, oh, we don't have equine therapy, we don't have enough speech therapists or something like that, right? Then you can say, I wonder if my CMH or my PIHP is meeting the standards of network adequacy. So you can come into the Medicaid manual and read what it says about what does Medicaid tell providers they have to do to make sure they've got enough of the providers of those services available. There's some things about, provider registries and some programs that require special approval. There's like, some of that more general kind of information that you might need. And then there are some, section 2 is all about program requirements. And here's where you can get to the yeah.
We're still seeing the first page.
Oh, well, that would have been good to know long ago. All right, let me unshare and reshare. Okay. All right, now tell me, if I click on this behavioral health, did it go to
Yes.
a table of contents?
It's
Okay,
moving.
you're now seeing the table of contents?
Yes, ma'am.
Okay, I don't know why it didn't do that before. Okay. Maybe it only lets you go one deep and I went too deep. All right. Nonetheless, so you're seeing all that stuff I just got done talking about, right? The network adequacy standards, program beneficiary eligibility. This is where you can find out who's eligible if you're questioning that. Confidentiality, lots of more general things. Then you get down here into section 2, program requirements. One of the things that I think is really important is this medical necessity criteria. This section 2.5 of the Medicaid manual tells you what the medical necessity criteria is. That information I quoted on an earlier slide, right? And the determination criteria. So this section here, 2.1 through all of section 2 really is all information that is really important that you might want to look up. Like if someone's saying that they don't think something you've asked for is medically necessary, well, you can come right to this section of the provider manual and you can read what it says about what creates medical necessity, and then you can use that in your argument, debate, discussion, whatever you want to call it, with your local CMH to make your case, right? No, this is what medical necessity says, and here's what I'm trying to accomplish. See how they match, right? And so this is a really important section. So you can keep going through covered services, right? This is covered services like that for like the general, for anybody in the state who has Medicaid, these are some covered services. And you can go through all of that, right? There's nursing. I mean, it gets right into like nursing facility mental health monitoring. So if somebody who has mental illness or even a developmental disability with some specialty mental health needs is in a nursing home, there is still a way that CMH plays a role. Occupational therapy, peer delivered services, all the services that are like available that you could potentially receive. Intensive care coordination with wraparound for children and adolescents. So here's where you have the wraparound information, in section 3.31. You just keep scrolling through and you can look for ACT, assertive community treatment programs, what's available, right? Clubhouse model, what's available. Crisis 7, home-based services, right? So there's the home-based. If somebody offers you home-based service, here's what you can look up. There's the inpatient piece. We have intensive crisis stabilization, which is, you can see this in blue. That means because it's been a recent update, April 1st, this whole section was updated. And so if you are someone who maybe your loved one lives at home or lives in the community and there's that need for intensive crisis stabilization services, you can look up what that really means. I'm going to tell you right up front, lots of CMHs they don't really have that all in place yet, right? They have been unable to hire enough staff to fill the need for this, but they're working on it. But you can know what you're eligible for. Then we have the outpatient partial hospitalization. I'm going to keep scrolling because I want to get down to down here. So if you have a child who's on the children's waiver, section 14 of this manual is important to you. You're going to want to bookmark it because that tells you it tells you who's eligible and what that looks like. It tells you all of the covered services. So community living supports, enhanced transportation, a fence around your house. When I first saw that, I was like, fencing? We're going to teach kids fencing? But that's not what I meant. The fiscal management services for people who are doing choice voucher, all of the things that you're eligible for when you are on the children's waiver, right? Specialized equipment. It just keeps going right on through. And then down here near the bottom, it talks about provider qualifications, right? So if you've hired a respite worker, what qualifications do they need to have? If you want to hire a case manager, you want to do maybe independent support coordination or case management, what qualifications do they have to have? This is where you can look that up right in this section. Section 15 is another important section if you have the habilitation waiver. You can look up, again, all of the services that you are able to receive. All of the services that a HAB waiver can get you if you need them are listed in this section, in section 15. If you notice, section 15.3 is a newer section, although it's not highlighted. I don't know why that is, but that's for people on the HAB service waiver if they're self-directing. Lyndia referenced the Waskell settlement earlier. This section right here of the Medicaid Provider Manual, section 15.3, gives you information about what that looks like post-Waskell. It's got information in there about how you organize your budgeting and your arrangement based on the Waskell settlement. So that's for those who care about that, that's a very important section of the manual. Sometimes when CMHs say, there's just been no guidance, I say, well, but there's at least something because it's in the provider manual. And then we have the what we call the I-SPA, right? The 1915 I waiver, which is the state plan. And that gives us all of the services that are available in that plan. Now, remember, Lyndia talked about how one of the things that's going to change here is that they're adding overnight health and safety. So in a future date, when you click onto this provider manual, you will see that has been added once it's been fully approved. So here's where we have the section 18 is really referencing applied behavioral analysis, ABA, and those services that are available. And then we get into, substance use disorder and some of the other various services and supports. And so you can just go through the index like we're doing right now. Oh, you questions about Michigans? We got it in here. It's right in here, and it talks about Michigans, talks about home-based respite, all of the different things. Now we have section 2110 is that waiver for children with serious emotional disturbance, the SED waiver. So that's an important section, right? And then we were talking earlier with Lyndia about the home and community-based services final rule and some of those plans of correction that just got approved by CMS. Right in here, right in our provider manual, it tells us what that means, what needs to happen. So like if you're thinking, man, I would love to have lockable doors, I'd love my kid to live in a place with lockable doors, you can come out here and click on this section where it talks about lockable doors and find out what is the rule about that. What are we supposed to be doing? What are we allowed to do under Medicaid around all of these different things, right? Here's that eviction and appeals information in the Medicaid manual, those protections that people have to not just be summarily evicted from their home if it's a group home or any kind of, home that they don't have the lease themselves. So there's lots of really good information about that. And then we have just some appendixes, some additional information. And so like if you did a search for children's waiver, it's going to pull up every reference to children's waiver so that if there's something specific you're looking for, you can easily find it in the manual. And so again, you go to you can just do a Google search, or you can use the website that I put in the slides. Click on Medicaid Provider Manual, get your index up, find behavioral health and intellectual disabilities, click on that, then click to get into it, and you are there. And you can either scroll through the index like we did, or the table of contents like we did, or you can use your search bar. So I'm going to unshare and go back to my PowerPoint here real quick. I'm doing a lot of sharing and unsharing. Sorry about that. Okay. Oops, and then it went right back to not where I wanted it to go. Oops. Okay, there's another place. Hang on here. Okay, so we just did the waiver. How can I find out what's available in the waiver? We just did the waiver. I want to talk about some other documents, though, that are really important. MDHHS often creates policy memos or updates, and they're intended to add detail and clarity to something that might be in the manual. You could also look up the contract between the PIHP and MDHHS. That outlines the responsibility of that PIHP to assure that things like provider network adequacy, for example, to assure that the CMHs are fulfilling all of the requirements, right, as a provider of those Medicaid services. You can also find the self-determination technical guidance and person-centered planning policy and guidance. So those are some of the things that you can find that are in addition to that Medicaid provider manual. Remember what Lyndia said, a lot of the stuff that's in the self-determination technical guidance is going to end up getting incorporated into the Medicaid manual in a future iteration. And a lot of the things that you see in the person-centered planning policy and guidance are already in the Medicaid manual, things like independent facilitation of the process and those kinds of things. But if you wanted to look for some of that information, this website that I've given you here, you just click on that and it takes you right to the MDHHS page that is focused on specialty behavioral health services. And you can kind of scroll through there and you can find some of that important information. So some additional considerations that I want to make sure, these are things that have come out of the manual that I just want to remind folks, right? The PIHP can deny services you're asking for if they are seen to be ineffective for what you're asking, what you need for your needs. If they are experimental or investigational in nature, or if there is another appropriate, less restrictive and cost-effective service. Now, I want to point this out, less restrictive and cost-effective. So you can't say, well, it's cheaper to live in this group home over here than to live in your own home, because that group home is not less restrictive, right? It's more restrictive. And so when you're hearing, oh, well, it has to be cost neutral, it has to be, the same price or less expensive. Remember, it also has to be the restrictiveness also has to either be less or equal, right? So you can't tell someone they have to live in specialized residential when they want to live in their own home because that's cheaper. So that's just, I think, important to recognize. And then the PIHP can also employ methods to determine amount, scope, and duration of services, right? So they are allowed to do some prior authorization for some things. They are allowed to do utilization management reviews. What they cannot do is allow those processes that they're using, those methods that they're using to fundamentally change your person-centered plan or change what you're going to be working on for your goals, right? They can say, is there a better way or a cheaper way to accomplish this goal? But they can't tell you you have to change your goals. So also, I just wanted to mention, again, that the PIHP can't deny services based just on cost. They have to look at the need for those services on an individual basis. And I think Lyndia mentioned that earlier too, right? This is all individual. And again, PIHP decisions that included utilization management cannot replace the person-centered planning process. So you can't have a case manager walk in and say, here's what we're going to give you at the beginning of your plan meeting because, whoa, wait a minute, we haven't discussed this. Now, the PIHP can, though, say, hey, here's some less costly alternatives that'll accomplish the same thing. Let's look at those, right? And then if the CMH is going to in some way edit your plan of service, that requires the person-centered planning process to be restarted. So where can you find help and resources? Again, the ARC Michigan website, Disability Rights Michigan website. There are local chapters of the ARC that have staff that can help you navigate the Medicaid provider manual if that's something you're interested. Disability networks. If you just want to learn more about the whole bigger system, you can go to the DDI, Developmental Disabilities Institute, or the Developmental Disabilities Council. And then MDHHS does have that beneficiary helpline. So if you're reading something in the manual and you're not understanding it, that would be a great use of that helpline. So at this point, I know I whipped through that really fast, and we can go back if folks want to, but I wanted to just make sure that we had time I saw a million questions popping up, so I want to make sure we have time for any questions.
All right, so now would be a great time to type any questions in the chat that you have for Jan. We have a question about the Clubhouse program in
Okay.
section 3.6. How widespread are these across the state? And is this for people with IDD?
Okay. Yeah. So the clubhouse model is really intended for people who experience mental illness. And I will tell you, years ago, I saw more clubhouses around the state than I see now. And I'm not sure why that is, but that's what I've seen in terms of the trends. I know in my region, like Midland County, we don't have a clubhouse, but they're in Saginaw County, they do. So it's like a local sort of decision. Clubhouses are typically very much driven by people with lived experience. And so often folks will say, rather than having a clubhouse, there might be like a drop-in center that's not exactly the same thing, or folks may decide to engage in more integrated community kinds of activities to meet the same goals. So, but it's typically people with developmental disabilities wouldn't be participating in a clubhouse model.
All right, thank you. Next question about the Medicaid provider manual. That's something that you would always want to be accessing online, correct? There's not a printed version.
Correct. No, you're going to access that online. I was joking. I said, I'll just quickly tell people, just print it, but don't ever print it. You can print a page to take to a hearing or something, but the Medicaid manual is very long, number one, because we were just looking at that behavioral health section, right? But it is many, many, many pages. And it also changes frequently. Remember, Lyndia was telling us just this morning that there are some things that are going to be getting added into the Medicaid provider manual based on the amendments to the waivers that are hopefully going to be approved very soon, and also that work around the self-determination guidance. And so I would say, I mean, I almost they make additions and changes and modifications to the Medicaid manual frequently. And so you don't want to ever print it. But what you do want to do is bookmark the web page so that you can easily get to that web page and then navigate through using your table of contents, right?
I am not seeing any other questions in the
Okay.
chat right now, Jan.
Okay. Okay.
But I definitely want to thank you for coming back again this week and pivoting to a great topic that was suggested in the chat last week. So we're nothing if not adaptable. So thank you, Jan.
Well, you're welcome. I would like to just say, just kind of like say one more time that the value of this for people is one to be just to know, right? To be informed about like what are the services and supports that I actually can legitimately expect to potentially receive if I'm on the HAB waiver or whatever. But also, if you're getting, if you're being denied something that you believe you are entitled to, being able to navigate the Medicaid manual to find the place where it says what that service is and what it's for, right? So that you can quote it when you're having that conversation with folks at your CMH, or if you have to go to Medicaid fair hearing or whatever it might be, right? So being able to get comfortable, I'd go out there, on a Friday night when I'm tired and want to just read something before I fall asleep and navigate through that and practice it. That's what I would suggest.
Right, we do have a couple more
Oh,
questions that has
okay.
come in.
Okay. I see
Um,
that.
So, what can you do if you're denied a service that is listed in the provide Medicare provider
Oh,
manual?
yeah, so that's what we talked about last week, right? You have due process rights. And so I would go back and take a look at the slides from last week and follow through with some of that process, right? So if you're denied something that's in the manual, you clearly can see what it is and you can see how it would help you. That service would help you achieve your goal, right? And you've asked for it and been told no, then you have due process rights. You start with that local appeal, and if you have to, you move on to that Medicaid fair hearing process.
Thank you so much. I'm going to put the link in the chat. Same place where you can find the PowerPoint for this week's presentation is where you can find the recordings from and PowerPoint from last week's presentations.
Oh, Tedra just said, what about mediation? Yes, if you read last week's presentation, you know that you could also seek mediation. That's one of the choices when we get past the local appeal. So absolutely, mediation or um, fair hearing. And if you recall from last week, if you start with mediation and you can't come to an agreement, you still can move forward with an appeal.
Thank you so much, Jan, for that additional information. There's one more question that I'm seeing. Do individuals lose access to their HAB waiver if they're in a specialized residential?
Okay, so the habilitation waiver, you can live in specialized residential. You can live in your own home in the community and use traditional provider agencies to receive your supports, or you can engage in self-directed services, right? You can do any of that. Now, there are some HAB waiver services that you cannot access when you're living in specialized residential. For example, you can't use the dollars to do home modifications in a group home. It's not your home, right? The home modifications are intended for a home that is yours, that either your name is on the lease or you own. So there are a few things or some things that are services that are available within the HAB waiver that are not necessarily available if you're in specialized residential, like home modifications. Um, but there are other ways to meet that need. So if you're in specialized residential and you need a ramp, that provider has the capacity to get that RAM for you, and they have the responsibility to do that, right? Because of their licensing and all the things. Um, so I would say that other than that, you know, private duty nursing, OT, PT, speech, all of those things you would be eligible for, even in specialized residential.
Jan, thank you so much for your insight. I'm not seeing any other questions come in at this time. So thank you, Jan. Thank you, everybody who joined us this week. This ARC Michigan Disability Policy webinar series is not here next week. We are off for observing Juneteenth, but come back again in 2 Fridays and catch up with us again with disability policy information on June 26th. So thank you, everybody, and have a great rest of your day.
Bye, everyone.